Hello, this is Dr. Mark Contos with another installment of Eyetube Journal Club, and with me today is Dr. Allon Barsam, who's going to talk to us a little bit about a paper that he just completed looking at PRK with mitomycin C in patients who have myopia and also have had previous adenovirus keratitis, and kind of interesting findings. Allon, thanks for joining me today. I was looking over that, and really kind of interesting stuff. You know, those are patients that you're kind of wondering, well, can we treat these people or not? You know, who can you treat with PRK or with laser surgery? And you've done some work that kind of helps explain some of that. Talk a little bit about what you found.
Oh, thanks very much, Mark. It's a pleasure to be here. The study is a very interesting study, actually, because infiltrates after adenoviral keratitis is actually quite a common finding, right. And myopia is pretty common as well. Yeah. So you have this subset of patients where the disease just doesn't go away on its own. So despite giving them some courses of steroid or just waiting for time to elapse, the infiltrates basically persist. And these are often young patients, and they have trouble with night driving or quality of vision, and basically the infiltrates, even if they're not in the center of the cornea, are interfering with their day-to-day function. Now they can put up with that for a while, but if they're coming back to you at 6 months, 9 months, even a year or more, and they still have these infiltrates, they say to you as an ophthalmologist, well, surely there's something that you can do to help me. Now if they also have myopia, especially if it's a significant amount of myopia, then what we showed in this paper is that by combining a treatment for both conditions, so essentially combining a treatment which has already been shown to be effective in treating persistent subepithelial infiltrates, which is using the eczema laser, which can be used either with PTK or PRK, but using it with PRK, which essentially is correcting their refractive error, has a big advantage, especially in the US, because the aspheric ablation profile, or the kind of advanced ablation profile, is only available with a custom treatment, so a wavefront customized treatment with a PRK treatment. So the ability to target the treatment to get rid of the infiltrates on their refractive error essentially gives them like a triple benefit, if you like. So you're getting rid of the refractive error, you're getting rid of the infiltrates, and you're giving them the most advanced kind of aspheric ablation profile from the laser.
Mm-hmm. Interesting. Now, when you started treating these people, did you see anything unusual at the beginning? Was there more, post-operative inflammation at the time that they were having their surgery, or anything? Were there differences that you noticed, or anything like that?
Not at all. I mean, it was amazingly uneventful, the visual recovery. With all of the treatments, we use mitomycin C, right. So that presumably prevents haze, scarring, and potentially even reactivation of the infiltrates. But one of the concerns might be, well, are the infiltrates actually having an effect on the patient's refraction? But in all cases, we made sure that the refraction was stable before committing the patients to treatment, and the refractive predictability of the treatment in every single case from day 1, week 1, month 1, and beyond was very high indeed. I mean, it was incredibly successful for this cohort of patients.
Now, you've followed these patients for about a year now, and anything kind of late, anybody coming in with any kind of issues with photophobia or any of the other symptoms that you sometimes associate with the infectious keratitis process?
No, not at all. I mean, there's been no recurrence. Whether the mitomycin helps with that, not sure, but certainly the ablation has helped with that. So I think a lot of the kind of pathology is in the subepithelial area of the cornea, and by ablating it, it's just not there anymore. So no, we had no problems at all.
How about steroid dosing, post-operatively? Did you make any changes from what you would do with a regular PRK patient that you're using mitomycin on, or did you make any adjustments in their dosage?
No, I mean, that's a great question. We didn't actually, because we just assumed that the mitomycin C would essentially do the work. Mitomycin C at the time of surgery would do the work for us. So we use a normal kind of 4-week post-operative steroid dosing regime that we would otherwise use. I mean, we obviously watched these patients really closely, and we were ready to change, adapt, or move our treatment around if we needed to, and we just didn't need to in any of the cases.
Yeah, it's interesting because you would kind of think that possibly, sometimes when you put steroid on those when you're treating the patient for those symptoms, post-infection and when they're over that, and they can sometimes be very dependent on that steroid, and it's difficult sometimes to wean them off of that to get them, to be symptom-free. So the fact that when you do this treatment, you don't really even have to deal with any of those kind of things is kind of an interesting finding.
Yeah, it's great. I mean, we know that actually giving these patients steroid has no impact on the final outcome. So all you're doing is you're just trying to essentially allow them to be able to live with a reasonable quality of vision until the disease eventually goes away. But for some of these patients, especially when it's severe or when it's really obvious and bothering them at the 6, 9, or 9 month or 1 year time point, they don't want to wait a few years with bad vision. I mean, the doctors, we think, well, it's going to go away, you'll be okay. But that's years of of annoyance for these patients, and so the ability to basically get them out of glasses, get rid of the problem for them, is very satisfying.
Yeah. Well, it's interesting. The other thing, just kind of thinking about that concept, is that, this, prior to looking at the data that you're presenting, you would say that might be a relative contraindication to surgery. But when you look at how these patients are doing, it actually becomes a reason to consider surgery, maybe perhaps when you might not otherwise. Say you have a patient who's had that condition, who also has a corresponding refractive error. Now you can say to him, well, look, you're having all these symptoms. We actually think that this surgery is going to, do two things for you that's going to be of great benefit. And that's kind of an interesting kind of dichotomy or a switch, really, or a paradigm shift, really, from where you might think that, well, those are patients, I might not want to do something with them. I'm worried how they might do.
Yeah, that's exactly right. I mean, there are safety considerations. So, for example, some of these patients get really dense, kind of coalesced infiltrates in the center of the cornea. And had we seen that, we might have used a masking agent at the time of laser, or done a transepithelial treatment using the epithelium as a masking agent. But most of these patients, the disease is in the kind of mid-periphery, and that's where their kind of symptoms and problems are all arising from. And then the other thing is to be as sure as you can possibly be that you are actually dealing with adenoviral keratitis. And a lot of it is diagnosed, clinically and on the history. But if we had any concern that we were dealing with something else, like potentially a herpetic keratitis, then we wouldn't have treated these patients. But they were all really typical in terms of the history of conjunctivitis, how it presented post-operatively, and how it responded to the steroids. So we're pretty comfortable with that. Well,
it's really interesting. The work that you're doing, obviously very important. It fills an area of fund of knowledge that's kind of lacking in this area. It provides some information for surgeons that they can go to and think about how to treat these patients. And it really adds to that. And I appreciate you taking the time to chat with us a little bit about it.
Thanks very much, Mark.
And that's another edition of Eyetube Journal Club, and thank you for joining us, and we will see you next time.